So thanks for having me, you guys. As Mini said, I'm Laura Haselden. I'm one of the docs at Georgetown and St. Mary's. You guys have heard from me in the past about buprenorphine. I've been told I'm not allowed to talk much about buprenorphine today, so I'm sorry if we get redundant. So what we're doing today is a little bit of a flipping the script. We talk a lot with drugs about drug cessation, but I think the patients that we see a lot of the time in the emergency room are patients that are not ready to stop using drugs. And these are the patients that I think are really frustrating for a lot of us. It's people that come in over and over again. They might have a little bit more challenging behavior, and we get really frustrated with these patients. We sort of anchor on the fact that, they don't want my help. I'm not going to be able to do anything with this person. And they just feel like probably the worst part of your day a lot of the time. And it makes us feel really helpless. And I feel like that contributes to our burnout, and it also really impacts our care of these patients. So what I want to do today is flip the script a little bit from how do I get this patient sober to how can I help this person come back when they're ready to get sober and not burn myself out in the process. So our objectives today are to sort of look at some of the things that MedStar is doing, but then also just sort of look at why we should be doing this and how can we expand this as sort of one of our obligations as ethical healthcare providers. I don't have any disclosures. I will give a disclaimer that if you have small children in the room, I would recommend you put in headphones, as we are going to have some explicit discussion of how to use illicit drugs today. So that being said, I don't think I have to convince you guys too much about why this is an important topic for us. I mean, we work in predominantly DC and Baltimore. We know that DC and Baltimore have some of the highest overdose rates in the country as far as fatalities. Just looking at the actual numbers of people that aren't dying but are still coming to the ER, this is a huge healthcare expense for us. I mean, the numbers in this are a little bit old, but in 2017, before the crisis got quite as bad as it is, we were seeing over $1 trillion in healthcare costs and over 100,000 cases a year in like soft tissue infections, endocarditis, things like that. So when I look at harm reduction, I look at this as both something we should be doing as an ethical obligation for our patients, but also something we should be doing to make our lives easier and to sort of save some stress on the healthcare system. So that said, this is a controversial topic. I think we've seen a lot of this in the news. A couple years ago, there was these headlines about Biden's trying to give everyone crack pipes. Everyone is sort of freaking out about this on MSNBC and Fox News and everywhere else. And it's sort of just been a little bit of a taboo topic where we've looked at harm reduction as something that street workers do, like street outreach workers, or people who are just like a little bit sort of on the fringe. And I think for a lot of us, it feels a little bit, it does feel enabling. It feels like if we're talking to people about how to use drugs more safely, we're telling them that it's okay to use drugs. But that's just kind of not a practical way of thinking about this. When we look at other pieces of medicine, we don't treat other things this way. Like if you have a patient with diabetes, with type 2 diabetes that's coming in, you're not going to refuse them insulin until they stop eating all carbohydrates. Like you're not going to refuse to treat their hypertension until they drop their salt below whatever limit you want to set for them. If you have someone with a physical disability, you don't say, I guess you're never going to walk again. You work with them with physical therapy to figure out ways to meet their life priorities and meet their goals and meet the reality of whatever they're able to do. Just we meet people where they are. But when we talk about drug use, we go back to this idea of I can't help you unless you stop using drugs. And I get that. I mean, we're all raised as members of society that, we grew up on the Just Say No, we grew up on Dare, we grew up seeing, Michael Jordan doing commercials about how drugs are going to kill you. We're all raised in this Just Say No culture, and it does feel, especially as generally professional white collar people, it does feel very taboo to talk about drugs as something that we're just going to accept. But I also think it's something necessary. The reason I care about this a lot is because when we perpetuate this attitude of you have to stop using drugs or I can't help you, we sort of contribute to the internalized stigma of our patients. As I'm sure you guys can sort of figure, our patients who use drugs have a lot of things sort of working against them. A lot of people are using drugs because of mental health issues, because of homelessness, because of history of, maybe not because of, but in correlation with history of incarceration. And all of these factors combined to sort of just form this superstorm of external stigma that then sort of goes into this person's psyche. And then when they come to the healthcare setting, they're already maybe not feeling great about themselves. They're already facing a lot of systemic barriers. And then if they come to the healthcare setting and we're just sort of writing them off as a lost cause, this sort of perpetuates the experience of stigma, which sort of perpetuates their own internal stigma. And without getting too in the weeds on this, because I'll talk about this all day, there's a lot of research that the more stigma someone experiences, the more internalized stigma they have, and then that drives really harmful health behaviors. So stigma makes people do more things that they'll be stigmatized for, is sort of the short version. So for us, what does this mean? It means if patients have had adverse experiences with the healthcare system when they come in, they're coming in sicker, they're less likely to comply with our plan of care, they're less likely to trust what we're telling them, and it makes our ability to provide care a lot harder. So this is sort of where we get to the first principles of this talk. It doesn't matter if your patient's using drugs. It feels kind of icky to a lot of us, but it's the thing that comes up a lot is you can't get sober if you're dead. So our goal is to, no matter what our patients want to do and are willing to do, we have to keep them alive long enough that even if you want them to come off drugs, you have to get them to a point where they feel safe enough and they're alive enough in order to do that. So whether you like it or not, you've got to harm reduce them enough to keep them alive. So in order to do this, this is the fun part of this talk. In order to do this, we have to sort of examine what kind of harms people are experiencing when they use drugs. So there's a lot of things. A lot of this has to, a lot of the harms that we actually see in meaningful ways are actually related to sort of the more social stigma and housing stability, incarceration, employment, things like that. But the things that we can actually do something about are the things I think are a little bit easier for us to talk about. So we'll focus on the first and the third category here, overdoses, and then sort of administration-related harms. So overdose risk reduction, I think we all know this really well. This is the big form of harm reduction that's currently offered by MedStar, offered by DC, offered in huge numbers in Maryland. And this is sort of what we know how to use. So as I'm sure you all have seen and given the fentanyl test strips, if not, your peer recovery coaches have, they're over here on the right. This is probably the most popular and the most sort of accepted thing that's given is we're having people test their drugs for fentanyl. I personally would argue that in our setting, fentanyl test strips are a little bit less helpful than they used to be because we don't have anything that doesn't have fentanyl in it at this point. If you're using any form of opioid, you're using fentanyl. So what's a little bit more helpful now that we also have is the xylazine test strips. I'm sure you guys have heard about xylazine. They call it trank dope, but xylazine's an alpha agonist. It's like a horse tranquilizer, essentially, that's in about 50% of the drug supply that's causing these really prolonged overdoses that can cause some hypotension, some bradycardia. So what I've started doing with the test strips is if people are using things that they think are not opioids, I give them fentanyl test strips. Like if you're trying to use party drugs, if you think you're using benzos, that's what you should be testing for fentanyl. And if you think you're using fentanyl, that's what you should be testing for xylazine. The other thing that sort of goes along with this is the education that you provide to what do you do with this test result. Like if your supply has xylazine in it, how are you going to sort of plan to reduce that? Are you going to reduce your dose? Are you going to make sure that you have someone with you when you're using? And sort of the same thing if you think you're using a benzo and you use a fentanyl test strip and it's positive for fentanyl. Most people who've spent money on drugs are probably going to use the drugs that they've purchased. It's just kind of not reasonable to tell them to throw it away. They're just not going to do that. But having a contingency plan of, okay, what are you going to do? Do you have Narcan on hand? Are you using alone? Are you using a smaller dose than you might initially start with? That brings us to Narcan. This is something that MedStar does super well, and we've actually had huge success in this in the past year. We're giving Narcan to everybody at this point who comes in with sort of any sort of substance use, which I 100% think we should be doing. It's free in Maryland, it's free in DC. Even if you're not in the hospital setting, you can just go online and request free Narcan, they'll mail it to you. And this has been like a hugely successful initiative as far as getting community saturation. And then obviously medication for opioid use disorder if patients are willing to stop using drugs. And then there's also a hotline called the Never Use Alone hotline. The principle being, don't use drugs alone so somebody can Narcan you. But for a lot of people, particularly like people living on the street or like sex workers, essentially, it can be unsafe to use with other people. So there is a phone line that they can call. You give the person on the phone your location. If you stop responding, they can send a responder to you. And then that brings us to my favorite part of this talk, the sort of administration-related harms. So this is what we see a lot, I think, in the ED. This is where we get into like the soft tissue infections, pseudoaneurysms, the scarring up all of your veins from injecting, some of the xylazine-related wounds. And this is what I used to call my how do you shoot heroin deep dive. We're a little bit short on time, so I'm not going to go super into the weeds on this. But the sort of short thing to know about this is there are sort of three main things that cause a lot of harm in injecting any sort of drug. The basics of obviously injecting drugs are you have to put a solid in liquid. So there's a lot of variation to how you do this as far as what drug you're using, what kind of what is it bound to, what salts is it attached to. But the short version is you put a solid in a liquid, you add an acid, and then you add heat, and then you put it in a needle. So as you might expect, this is kind of how we prepare a lot of drugs, even in the hospital setting. But this also introduces a lot of opportunities for contamination and infection. So things that we see a lot of injuries from are people using just things that aren't sterile. So people will use lemon juice instead of sterile citric acid as their acid, or people have reported using puddle water or toilet water instead of sterile water as their water that they're dissolving their drugs in, or people are using tobacco filters instead of sterile cotton when they're filtering their drugs. And all of these things cause a lot of injuries, a lot of infections. The acid can cause damage to veins. Obviously, using toilet water is probably not a great sterile preparation for anybody. But all of these things we kind of have to know about in order to have these conversations with our patients. So when you're talking to your patients, just that sort of basic question of what drugs are you using? How are you using them? Are you shooting? Are you smoking? Are you snorting? And then if people are shooting in particular, how are you actually preparing your drugs and how are you injecting? So I won't totally belabor this point with you guys because we all know how to inject things safely, but a lot of our patients don't. So if patients are still injecting, talk to them about how they're injecting. How are they choosing a site? Are they washing their skin? Are they using a tourniquet? What kind of needle are they using? Are they going straight to big veins or are they starting peripheral? Do they know how to find that? And then are they sharing needles? Are they reusing needles? We know that when you're putting in a central line, you put the needle bevel up. Your patients might not, and just that really little change could make a significant difference in how much damage they're doing to their veins and their risk of infection. So the other thing, and this is probably one of the hardest conversations to have with patients, is if you're injecting, if you have infections from injecting and you're going to continue using drugs, can you do something else? Can you not inject? So this is where we get into, could you smoke? Could you boof drugs, which is rectal administration of drugs? This is a little bit of a harder sell with a lot of patients. What we have seen lately is a lot of patients have transitioned to smoking with the change to pressed fentanyl pills, which I think is actually totally fine. I think most people psychologically are okay with changing to smoking. You'll occasionally have a patient who sort of has a ritual with their injecting. For those patients, boofing might be a really good option. The high is a little bit stronger than probably smoking and IV administration. And it has the same ritual of preparing your drugs, but then the last step, instead of injecting the drugs, you just rectally administer the same syringe that you would normally prepare. Again, this feels like a really, silly taboo topic conversation to have with your patient in the emergency department. But I think even if they don't want to change their route of administration, the fact that you're willing to have this conversation with them is a really helpful thing. Other things, we sort of know we need to be testing people for HIV. We need to be talking to people about safer sex. We need to be talking to people about, hepatitis C, disposing of their needles appropriately, where they can go to get clean needles, things like that. And that's not a super time-consuming thing for us to do in the ED. I won't belabor this point, but buprenorphine is also a huge thing as far as how can we keep people safer? If you're on enough buprenorphine, you cannot overdose yourself with fentanyl. So I do think continue thinking about buprenorphine, continue offering people buprenorphine, even if they're not quite ready to get totally sober. And just continue being a safe place for your patient to access care. So our TLDR, how do we get people to use drugs more safely? We have to be a safe place where they can come and look for help, even if they're going to continue using drugs. We can talk to them about smoking instead of injecting. They're less likely to overdose for something where it's easy to redose. There's pretty good literature that suggests that if people have access to crack pipes, they're less likely to inject. If they're open to switching to boofing, if they have access to citric acid instead of lemon juice or vinegar. And then can we just talk to them quickly about how to inject safely? Yeah, continue with your MedStar officially approved resources like your xylazine and fentanyl test strips and your Narcan. And if you guys ever have any questions about this, you can always text or call me, and I'm happy to give you sort of on the ground recommendations of what your patient can do.